Hello everyone. We are discussing various X-rays under the space reflection. How the various anatomical landmark reflects on the X-ray. We'll see step by step. So this is Professor Dr. Prashant Dosari welcomes you on this emerging MEDTALK. Discussion of topic is practical approach to X-ray shoulder joint. So various dislocations, various fractures, they are dealing with the shoulder. But before that, clinical condition, will discuss the normal anatomy. So various views, particularly important is antero-posterior view, then the lateral and then the axial view. So here this antero-posterior view of X-ray shoulder joint. So the approach is very simple, ABCS pattern. A for this alignment, B for the bones, various bones, C for the cartilage, and S for these soft tissue. So first we'll discuss this alignment particularly. So here we can see shoulder girdle having one of the bone joint is this at this is the clavicle lateral end, and here is the acromion, we can say the process, and at this particularly the joint is what, acromioclavicular joint. This is a plain joint, and then this is normally aligned. And second, commonly very important is the head, what we can say this of this humerus. It articulates with the glenoid cavity of this scapula. So this is glenohumeral or the shoulder joint. So these properly should be aligned. So this is what the alignment we have seen. There should not be dislocation, or the distance should not be more than the normal. So this is what this alignment particularly. Then we'll discuss various bones. So in the under this B, so here is the head of the humerus. This is a greater tubercle. Here will be the lesser tubercle, and in between is intertubercular sulcus or bicipital groove, and it continues at this upper end as this as a shaft of the humerus. So, and simultaneously there are two important necks are there, where the upper end or the head, it separates from the upper end. This is the anatomical neck, and where the fractures are common is the surgical neck of the humerus, where the axillary nerve may be damaged. Then this is the clavicle. On this will be the medial side, here will be the lateral end of the clavicle. So this is the clavicle. Then the scapula having this is the this is the lateral border of the scapula. Here is the glenoid, we can say the fossa, which articulates with the head of this humerus. Then having various processes, here is the coracoid process of this scapula. Here is the acromion process, and here is the, we can see the, here at this will be the spinous process of the scapula. So whereas we have seen humerus, then the clavicle, and the scapula and its various, we can say the parts. Then cartilage, because we know at the bony ends particularly lined by the cartilage, so they are not so seen clearly on these x-rays. But if there is a narrowing of the joint space, there may be a degenerative condition, osteoarthritis, or if the space is widened, it may be due to the ligamental injury, or what we can say the dislocation. So this C. And lastly the soft tissue. So here we can see the soft tissue particularly surrounding the joint cavity, particularly various muscles, and if there is a fluid collect surrounding the joint, there is a effusion, and if there is a foreign particle, we can have the various representation on the x-ray. So this is what very simple antero-posterior view of the shoulder joint. We can this correlate with these various bones. So here is, we can say the humerus. Here is a humerus having this greater and this greater and lesser tuber, and here we can say that this intertubercular sulcus or bicipital groove, and here this is the shaft of the humerus. Here is the head of the humerus. This is the scapula, and we can see the acromion process. There, this is a coracoid process and also the spinous process, and here we can see the lateral border, medial border along with inferior angle, and above will be the superior border along with the superior angle. So this is scapula. And very important is the, we can see the glenoid, we can say the fossa or the cavity of the scapula articulating with the head of the humerus. Here we can see the lateral end of the clavicle, and here we can see the middle end of the clavicle, and at this point is the acromioclavicular joint, plain variety, and here is a glenohumeral joint, that is nothing but the shoulder joint, which is of ball and socket variety. So this is very simple how it represent on the these bones. So the second view, lateral view, here we can see particularly this, also called as Y view, because this is, we can see here is the clavicle, here is the acromion process, these are the, we can say the coracoid process here, and this is spinous process along with this acromion, and when we join these lines, so there it appears as the Y. So it appears as Y. So here this is posteriorly will be the, what we can say, the acromion, and this anteriorly will be the coracoid process, and when we join these 2 points, and it comes down along the body of the this scapula, and this bifurcation of the Y lies at the level of the head of the humerus. So this is what very simple the lateral view of the this X-ray shoulder joint. So we can see here very clearly the body of the scapula, then there is, this is the glenoid fossa, here is the coracoid process, here is the acromion process, here is the spinous process, and how it appears on the X-ray we have already seen. Then third view is the axial view, less commonly we do, but here we can see here, this is what from the above we have taken superior projections. Here is the head of the humerus, and we can see the acromion process, here is posteriorly, anteriorly coracoid process, and how the head of the humerus this articulates with this glenoid, we can say the fossa or the cavity of the scapula. So the from taken from the above, this is axial view. So we have discussed 3 views, mainly anterior posterior, then lateral, and in short the axial view. Then we'll see some clinical conditions in brief. So very commonly there is anti-dislocations more than 95%, and we can see the humeral head lies below the this coracoid. Here is the coracoid process, here is the humeral head, there is a what we can see, there is alignment is distal, and there is a dislocation anteriorly below the coracoid process. We can see here how the in this direction. So this is anterior dislocation, very common. Less common is the posterior dislocation, where we can see the classical light bulb appearance. So we can see here how this posterior, this particularly head like that of the this is light bulb, and less common this appearance. Another maybe involved with there is a inferior dislocation also. Then acromioclavicular joint dislocations, particularly in the trauma, may be there, and we can see there is a loss of alignment here, and we can see there is acromioclavicular distance is around normally 5 to 8 millimeter. It becomes more than that. Coracoclavicular distance is around up to 13 millimeter. So this distance, coracoclavicular distance is 30 millimeter. If also widen, so there is dislocation called as acromioclavicular joint dislocation. So various fractures here involving the head of the, you can say the this humerus, and there is a loss of cortical continuity. Here we can say the fracture at the this surgical neck. This is very common and may involve or damage the axillary nerve. Then also the fracture clavicle, this is again history of trauma, and there is most commonly at the site of the shaft, medial 2/3 and the lateral 1/3, and the joint space may become narrow, and particularly old age degenerative conditions where they called as osteoarthritis, where there is subchondral sclerosis, joint space narrowing, and there is also bony erosions. So this is osteoarthritis, and also some clinical condition may relate to this calcification of the supraspinous tendon may cause pain in old age also. So this is what some clinical conditions we have discussed, and tips particularly you must know, or you can remind the shoulder girdle having three joints, then the glenohumeral, this is multi-axial ball and socket, then acromioclavicular plane joint, and that's medially, that is sternoclavicular joint, that is saddle variety. And shoulder joint is mainly formed by the articulation of the head of the humerus with the glenoid cavity of the scapula, where the head having its more contribution or the more than that of the glenoid cavity. Joint space is radiolucent, and we have seen the bony ends lined by the cartilage, and there is a narrowing or the dislocation, particularly involving. And when there is a dislocation, anti-dislocation more common, that is more than 95%, posterior dislocation less common, appearance is light burr, and along maybe there in very small percentage inferior dislocation. So this is how we have discussed this X-ray shoulder joint under this ABCS system. And I hope you like this video. If any queries, any suggestions, you can add in the comment box, and you can subscribe if you like it. And we have various X-ray series on the whole body, so we'll discuss step by step. So this is all about the this shoulder X-ray shoulder joint. Thank you.